Hello, everyone, and welcome back to the Flint Community Webinar, your community resource. It's good to have you back. I'm Jennifer Edwards Johnson. I'm glad to be able to present all this wonderful wealth of information we've got for you today. I'll tell you, for the last week, I've been working with a virtual background, but it was sunny outside today, and I wanted everyone to see the sunshine coming through because we've got a bunch of enlightening, amazing people who are going to bring the sunshine to you with all the amazing resources they have. We've got some regulars. We've got Dr. G and Nurse T, always here to tell us what the community's thinking about. Today, we're going to talk to, we've got Genesee Health Department that's going to talk to us a little bit about their listening session that they have coming up. We're going to be talking about preconception health, and we've got a multidisciplinary team to talk to you about what that looks like. And we've got Dr. Aisha Harris from Flint back to work with our wonderful team from nursing and from undergraduate research assistants at MSU who are going to be talking to us all about that preconception health. And then we're going to talk a little bit about prescription drug costs. So we've got Dr. Taylor here and Jim Milanowski from the health plan. And I see Nurse T mentioning some things. What did I miss, Nurse T? Oh, and an event that you all should check in the chat that Nurse T is going to tell us about a little bit later. So we are packed with important information. Let's get started by talking to the health department about their listening session.
Well, thank you for having us today. And I am Michelle Estelle, the health officer at the Genesee County Health Department. So we are working on developing our strategic plan. We partner with the U of M Flint's Department of Public Health and Health Sciences to conduct a research study focused on health needs and access to services in Genesee County. We really would like community input. The community input is essential. So we want to hear directly from residents and those who serve them to make sure that we have all the services and that our community reflects the needs and priorities of the citizens and those who work and play here. This work is supported by the Genesee County Board of Commissioners, and it aligns with the county's common purposes, priorities, and values.
Thanks, Michelle. So a little bit about who should participate in these listening sessions. We have two different types of sessions. We have community listening sessions, and this will be for Genesee County residents. And we also have stakeholder listening sessions. So these will be for professionals and organizations that serve the community. Examples are healthcare workers, educators, first responders, community-based organizations, and also faith-based organizations. One keynote is that we are excluding Genesee County Health Department employees and their immediate family members from the listening sessions. And
So,
a little bit,
go ahead.
Yeah, go ahead. Oh, sorry.
No, go ahead, Brent.
For those individuals who would like to participate, like I said, we have community listening sessions and stakeholder listening sessions. There will be a variety of sessions throughout Genesee County. They're going to be in person. As a thank you for those who are participating, we're providing free food at the sessions and $50 gift cards, and you'll be able to choose a fuel or a grocery gift card. We're also providing accommodations for transportation for those who may need getting to the listening sessions and back home. And also we'll have interpretation services provided for ASL and Spanish and Arabic speaking individuals. So the flyer you'll see on the screens, we have two different flyers, one for community listening sessions and one for stakeholders. There's different links and QR codes on each, has all the information that Michelle and I are discussing. And I think that's it for me. I'll hand it back over to Michelle.
So, what is our ask of you? Please help us spread the word by sharing this opportunity. Again, the flyers are there and it's also on our website. If you wouldn't mind posting the flyers, forward the sign-up links, and encourage residents and partners to participate, that would be really helpful to us. And your support will help ensure diverse voices are heard and included, and it'll help us shape our future or shape the future of health in Genesee County. So we would really appreciate any help we can get with this. Thank you.
I see homework. You're giving us homework?
Yes.
Yeah,
Help.
there's a
Collaboration.
mini homework assessment, or it's a survey, a pre and post survey for the listening session.
Got it. So this is going to help you understand kind of the needs of the community relative to their health needs. And so it's not bad homework. How about that?
Yeah.
All right. Super appreciate you for bringing this information to us, and definitely try to do your homework and go to the event and get your gift cards.
Thank you for
Thank
letting
you.
us share.
Absolutely. Absolutely. All right, let's bring up our next group of experts. All right, we've got Eliana Hollis, who's one of our nursing students. Taylor Cease is one of our pre-nursing students, and we're going to try to recruit Jamie Parker to be one of our med students in a future Flintstone. And Emma Schlegel, thank you so much to all of you for talking to us today.
Thanks for having us. So I'll share our slides, and we're going to talk about something that I'm very passionate about, and that is preconception health, specifically for emerging adults. So 18 to 25-year-olds is kind of the population I focus on as a researcher in the College of Nursing at Michigan State. And I have 3 of my wonderful undergraduate research assistants with me, and they'll help me present. So let's see. I just want to acknowledge that some of the research I'll share was funded by the Michigan State College of Nursing, as well as the Michigan Nurses Foundation, and we have no conflicts to disclose. So I'll turn it over to Taylor to get us started about emerging adulthood.
First, I want to start off with some background information about emerging adulthood. This is between the ages 18 to 25 years. Some may say it goes up to 29, but we mainly focus on 18 to 25. Our study focuses on individuals. Oh, I said that already. Sorry. Emerging adults are in a period of high risk taking, increasing independence, unique health risks, financial, career, and health insurance instability. Such characteristics make them vulnerable to risky health behaviors and can lead to poor health outcomes. Next slide. Additionally, 18 to 25-year-olds are less likely to have a usual source of care, referring to clinics or emergency departments. They also contribute to the higher rates of unintended pregnancy and sexually transmitted infections. All right.
That is a little bit of the background of why we focus on this age group specifically. In terms of preconception health, on this slide, we've listed kind of the domains of preconception health and what is relevant in the period prior to any pregnancy, planned or unplanned. And I've bolded the topics that are most relevant to emerging adults. So, understanding of their reproductive capacity and fertility. Emerging adults are less likely to own their homes, and so they may be exposed to environmental toxins that they're unaware of. They also can be exposed to teratogens via medications that they take, just chemicals that they're exposed to. They also have lower nutrition. They could be at risk for food insecurity. They likely are not supplementing folic acid. Research shows that they're not supplementing with folic acid. More likely to be using substances. Also more likely to be exposed to infectious disease, including STIs, like we mentioned. And then also there are psychosocial concerns, so related to their mental health and financial status. So all of these factors kind of put them at higher risk for poor preconception health. And so with my research, I focus on this topic in this age group, and it's driven by an understanding of how emerging adults interact and manage their sexual and reproductive health or preconception health. So in prior research that I've done, we found that a lot of the learning and decision making is occurring through conversations with trusted individuals or confidants. You can see that here on this diagram. And participants in my studies have made it very clear that a lot of times healthcare providers are not involved in those conversations. And if they are, they're getting kind of the cliff notes of the information. And so as healthcare providers, it's really important for us to acknowledge that and understand kind of the practices of emerging adults and how they are making their health decisions. And so for the most recent study that I've conducted looking at preconception health, we had 3 research questions. We wanted to look at how health literacy and preconception health knowledge was varying between individuals with and without a usual source of care. Like we said, emerging adults are less likely to have a usual source of care. And then also between individuals with different confidants or primary sources of sexual and reproductive health information and decision-making support. We also wanted to explore emerging adult individuals' preferred strategies and tools for preconception health promotion. There's not a lot of research done with youth about preconception health, and so that we kind of wanted to start with the perspectives of the emerging adults. So we recruited individuals using technology, and we tried to avoid recruiting out of clinics because we wanted to reach emerging adults where they were and didn't want a sample of only individuals who have already sought care. And so we used social media advertisements and used a health research volunteer registry. And then we designed our flyers with the intention to be inclusive of individuals who may not identify as women. We wanted kind of a representative sample to base our findings off of. So this slide just highlights some of the demographics of our participants. We ended up getting 245 survey respondents. They were on the older side of our age range, so mostly in the 22 to 25 year age range. We did collect a representative sample of cisgender heterosexual and sexual and gender minority individuals, and 25% is about representative of the emerging adult population. And then you can see here, only about 60% had a usual source of care, and that was seeing the same provider at least more than once for their sexual and reproductive health. So kind of low bar. And then also about half reported the internet or social media as their primary source of sexual and reproductive health information and decision-making support. And then the remaining half were split between lay people and healthcare providers.
Dr. Schlegel, can I ask a question? So if I'm hearing this right, you've got about 225 people you surveyed. About 60% of them were people who had regular access to a provider. And these are young people, 18 to 25. By the way, I take offense to older people being 25. Feeling that personally. But okay, so you got 60% of them who actually seek care regularly. And then amongst that group, half of them get their information about medicine from the internet.
Yeah, so we have
not the internet, but like social media.
Yeah, so even the people who had a usual source of care, a portion of them still chose to use the internet or social media for their decision making. So we'll talk kind of about that. Yeah, it's surprising and concerning.
We're doing a bad job is what I'm hearing. Like us family doctors and the like pediatricians on the screen are like just failing here.
It is reflective of what I found in the past that, you know, they have conversations with their providers, but often it's very shallow or, you know, it's the bare minimum of information. And so it's, yeah.
And can you tell me, and you might be getting into this, does the data suggest that, like, and you kind of hinted at this, is it we're not asking the right questions, or do young people not feel comfortable sharing that type of information with their providers?
I think it's both. So trust is a huge thing and it's lacking. A lot of the, at least qualitative data that I've collected, participants talk about kind of dismissive and disrespectful interactions with providers, which makes them less likely in the future to disclose information and have like a deep conversation. There's also literature that, I mean, as providers, I know you all don't have time, right? It's a limited amount of time that you can spend with each patient. And so sometimes the questions that need to be asked don't get asked, or you don't have time to kind of get into the details. And so a lot of times emerging adults are waiting for providers to bring topics up, and it's not often happening.
Okay. So for the people who are like tuning into this webinar, one, those of us who are providing care need to get into people's business more, basically. Like we need to ask more questions.
Mm-hmm.
Two, the young people who are seeing their providers kind of have to be willing to be a little bit vulnerable. And I understand that means we've got to do the job of developing trust, but just making sure they feel comfortable and have a safe space to be able to talk about those things. This is really helpful and interesting. Thank you.
I'm glad. Yeah, so we looked at, right, differences in health literacy and knowledge. What we found is, having a usual source was important for feeling understood and supported by healthcare providers, having sufficient information to manage my health, and navigating the healthcare system. But then when we looked at primary source of information and decision-making support, there were more different significant differences. So it does seem like the primary source is more relevant and important than having a usual source of care. And so you can see those additional scales of health literacy that were significantly different. And so people who do report their healthcare provider have higher health literacy, which is not surprising. But what is a little surprising is that there are differences, right? So for social support, there was no difference between a healthcare provider and a layperson. For appraisal of health information, there was no difference between the groups who report a healthcare provider and those who report the internet. But there was a difference between those reporting a layperson and a healthcare provider as their primary source. So some nuances that we're still kind of exploring. But like I said, it does seem like the primary source is kind of the most important thing. And then in our interviews, when we talked to participants about their preconception health, what came out of our preliminary analysis is that they view preconception health as a life stage with specific entry requirements. So they're not necessarily thinking about it until they're in a committed relationship. They know definitely that they want to have kids. They're more financially stable. And even though it wasn't necessarily conceptually relevant to them, they did identify with those health domains that I shared with you all as important currently. And then they mentioned relationships with providers, and positive relationships are influential, but negative relationships are just as influential and more common, at least in the participants we interviewed. And then in an ideal world, I always ask my research participants, if you could have an ideal world, what would you want? What would it look like? They want the culture and providers to center and empower their individual informed choice. So a lot of times they talked about having a mix of professional and personal experience and information to make their decisions. Having providers share accurate information, but then ultimately honoring their decisions and respecting their decisions. So kind of key takeaways that we've already hit on, 41% didn't have a usual source of care. If they did have a usual source of care, they were more likely to report the healthcare provider as the primary source. But again, there were still, portions of that group who reported the internet or a layperson as their primary source of information. And again, about half reported the internet or social media as their primary source. And then, as I mentioned already, there's some preliminary evidence that the source of information is more influential than the usual source of care. So now I want to turn it over to Eliana, and she's going to share about how we are trying to give our research information back to our participants in a way that's meaningful to them.
Dr. Schlegel, could you go back to 2 slides? One more.
Yeah.
So when in this theme, positive relationships with providers are rare yet influential. I'm trying to get my soul back because I feel so sad about this. But tell me a little bit more about what that means. What did you get any insight into what a positive relationship looks like and what your participants sort of experience positive relationships as?
Yeah, so we have a couple of slides about what providers can do,
Awesome.
but and if you want, I can skip to those now, and then.
No, I did not mean to redirect your presentation. I was just curious and probably sad.
Yeah. So we'll talk about that. And then also, I think in terms of, it was more common that people would share negative experiences, and it was really like the dismissive interactions, like their, thoughts and priorities weren't necessarily honored in the interaction. And I think the literature also shows this, that with this age group, it's all about like highly effective contraceptives, but there's a lot of pregnancy ambivalence and
Okay.
people choosing not to be on hormonal contraceptives for, whatever reason
Sure.
that is valid for them. But I think as providers are so focused on, preventing pregnancy that we aren't listening to them when they, don't necessarily want to prioritize that.
Got it.
And so there are strategies then to move to, health optimization and making sure if a pregnancy occurred, we are, encouraging healthy preconception health.
Well, you have told me that mostly providers need to listen, and so I will listen to your undergraduate research assistant, who our this age group would probably care to hear more from. So thank you, Eliana. I will let you give us your information.
Okay, so I kind of came on the research team when the Promoting Health for Her study was not exactly complete because we were still working on dissemination, but I kind of looked at it from that viewpoint. So I kind of was looking at, okay, so we have half of participants that are using the internet and social media for their sexual reproductive decision making. What is a way that we could kind of get through to them in an infographic while also conveying and returning their results? So what I did was I completed a literature review to look at how they prefer their research results to be returned to them in what format, as well as how they verify this online health information that they come across. Because I wanted to make sure that, I mean, obviously they participated in the research study and they trusted us, but also did they trust our results? And is there a way that we can kind of promote better information seeking? So I kind of took away from that a kind of infographic as a way to convey these results to boost engagement with the dissemination of our study results. So I kind of wanted to use that to basically have all the markers of credibility as well as to return the results themselves. So this literature review, I used PubMed as well as Google Scholar as search engines, and I located about 23 articles that were included in the final review. The data was then synthesized into a infographic that kind of incorporated those markers of credibility as well as the results from Dr. Schlegel's study. So the formation of the dissemination infographic. So we had multiple versions of the infographic, which I will show in like the next slide. But it was very helpful to have the research team having Taylor as well as Jamie, and then also Allie. She's not here right now, but we're all kind of in this age range. So just being able to hear their feedback as well. So the final version of the infographic kind of tied these important themes into a sort of analogy so that it was easier for people to grasp and also to think about in their everyday life. So we kind of use a flower as a kind of symbolism that participants would need to water by identifying areas of improvement, connecting with those healthcare providers, and also being critical of what they're searching online. So this is the progression of our infographic. So on the far left was the initial infographic that we started with. We kind of deleted the purpose and method section because we figured that they were aware of that since they participated in the study. And then the second one in the middle, we kind of wanted to focus more on kind of harping on the benefits of having a regular provider and kind of conveying a message there. And then the last infographic is where we kind of came in with the flower analogy and
Oh, I see it. That's so cool.
yeah. So yeah.
This is really cool.
So here we I circled a few parts of the infographic where we included what we gathered in the literature review. So one thing that adolescents, young adults look for in online information is some form of statistics or graphs. So we kind of have that as number one there. They also are looking for verification. So I wanted to make sure to include the College of Nursing logo so that they know where this is coming from. Also, credentials and expertise. So I included my name as well as Dr. Schlegel's credentials and her contact. We also included some citations on the bottom right, as well as evidence of recent updates and when the infographic was created.
This is bananas cool. So, okay. So you've told me, like, you've told us a bunch of different things. One, that this age group is really interested in some marker of credibility that includes data, right? So if we're making infographics, if we're making things for this population, this generation, having some data is important. Your second one, the verifications. What's the verification one again?
So that was just kind of making sure that they like know where it's coming from. So, I mean, more on the literature review, it was kind of looking at like domains like .org or something like that. But obviously on the infographic, we couldn't really, it wasn't a website per se. So I just kind of added the College of Nursing logo to
some authenticity. It's very, so that makes a lot of sense. Like, who they want to know the expertise of the authors, citations, evidence. So you put the date there. Like, I feel like we both learned about how to create infographics that are helpful to people and about health literacy. This is super, super neat. I want to be thoughtful about how much time you have, and I want to get some discussion around this going if we could. I know we have Dr. Harris and Brittany Taylor. Yes, hit this too before we get
Jamie was going to talk about this, but we can just leave it up also during the discussion.
Jamie, give us a quick summary of this and then let's get into the discussion, because I think this is the information we really need to understand.
Yeah, I definitely will. So basically, during the research, we found recommendations to give to providers when approaching sexual and reproductive health. So as you know, most emerging adults aren't actively thinking about their health in the context of preconception. They may be concerned about grades, jobs, and relationships. However, this doesn't mean the guidance of providers isn't valuable. So providers, they really need to be influential, even if the patient isn't currently thinking about parenthood. These early conversations can plant a seed for long-term health awareness and decision-making. The internet and social media are major sources of information and misinformation. That's why it's essential to ask emerging adults where they're getting their information from, not in a judgmental way, but just out of curiosity, so that we're understanding their sources, and it helps us better address misconceptions and guide them towards credibility. So from there, providers should offer accurate and evidence-based information, but more importantly, providers should do so with the goal of empowering informed choice, not just delivering instructions. Providers' role is to support the young adults in making decisions and what's right for them, based on facts, not fear. And another challenge that I know providers do have is time. When young adults come in, it's for flu shot, STD screening, or even birth control, and there's not a lot of time. You only have 20 to 30 minutes to really build that rapport. So we have to think about rapid trust building, ways to make them feel safe, seen, and respected in just a few moments. And that can mean something as simple as just using inclusive language, affirming their privacy, or validating their concerns before you dive into the education. And these small shifts can create those meaningful connections.
I'm like floored right now. This is awesome. Okay, super cool. You've got amazing people in the chat. You've got Brad Snyder from the health department. You've got Jim Milanowski from the health plan, all talking about how we need to use this type of approach for our education that we're doing for young adults. So super, super appreciate this. This is super dope.
Yeah, of course.
All right, I want to get us talking about this because we've got like a bunch of old people who want to talk about how we can do this better.
Yeah.
We're not that old, in fairness. Okay. All right. I see Dr. Harris. Maybe we can spotlight me, Dr. Harris, Dr. Taylor. Awesome. Let's get Dr. Taylor in here too. So, Dr. Harris, you are relatively recent grad. You've got a young population that you see. Tell me about your approach when you are talking to young people about their health in general.
Yeah, I guess it's multiple approaches depending on kind of the person and the problem. But one of the things that I try and convey is that it's like a two-way street of kind of information and stuff. You all were talking about how much stuff is online, and I'm human too. So I am not afraid to admit I didn't know that. Like someone told me the other day that they heard a medicine possibly cause cancer, and I'm not gonna like dispel it unless I like completely know it's possibly false information. But one of the things that I try and let people know is that the internet has a lot of information available and it's not always vetted. And now when you Google something, AI pops up with a summary that who knows where they get that summary from. And so I want people to do their research on their medical problems. I want people to be involved and engaged in their health journey and the health process. But I also want them to utilize me as a resource and feel like, I am vetting the resources that I'm looking at and what I'm saying to patients, and I care about the results and not just kind of repeating something just for the sake of repeating it. But I think the information is kind of information overload, but it's also great to have that information available because it makes the discussions very enlightening and informative for me and the patient. But I think when people, especially young people, are trying to get involved in healthcare, a lot of times they haven't engaged that long. And so what they've seen and what they've heard is from their friends, is from the internet. And so we're trying to establish that foundation in that relationship so that way they trust the system and they trust me as their provider, but they also feel like they're bringing something to the table and they're really involved with their health. And so like I said, it's a two-way street of information, but I enjoy the discussion and I learn new things, and I'm not afraid to look up the stuff that they say, but I'm also not afraid to say, no, that's not true. And once I build that trust with my patients, when I say that something's not true, they often believe it because I'm not just saying it just to say it, and I didn't just dismiss what they said because it was possibly hearsay. Like if I don't know it, I don't know it, but I will let you know what is true and what's not true so we can kind of build from there.
It's interesting. Dr. G put in a chat that there's a meme floating around saying, take care of yourself because the new doctors are Chat GPT trained. They are not. I train them. They're phenomenal. They're going to be great doctors. You're going to be in good hands. But I think the flip side of that is we do need to be Chat GPT trained because these are the resources people are using, right? So we need to understand and use the resources that other people are using. And I see Dr. Taylor like nodding her head. So I want to hear what you've got to say.
No, I feel like I echo so much of what Dr. Harris said. I mean, I feel like if you don't meet the patients where they're at, and that means in their knowledge base or where they're coming from like what, like lens that they're coming from, that you're never going to connect with them and you're never going to get to that. And so I feel like a huge thing I usually do is, I think Dr. Hurst basically said this too, is that when someone comes in and says, oh, I'm concerned about X, Y, and Z for this, I'm like, bring me that resource. I want to look at this too. Because a lot of times there's like a small grain of truth in that might have been manipulated one way or another to do a lot. I mean, a lot of what goes on the internet is to sell a product. And sometimes there's good people out there doing good stuff, but they still got to make money. So, it's kind of balancing all of that and putting that together and then making that individualized for that patient in front of you with their value system, which might be different than my value system, and maybe what the healthcare system values as well. And making sure that we meet somebody where they're at. And I think this is a big thing that we've been trying to do more in pediatrics as well. I see, young kids. And so at 11, we ask the parent to step out. So that way, the kid and I can have a discussion and take ownership of their health to hopefully for these emerging adults, as you were talking about, when they're 18, the first time that they go to a physician or a healthcare provider isn't when they're 18 and so they have more comfort navigating that system. And I think that's something that we really need to, I'm med ped, so it means I take care of adults and kids. And so there's this thing called transitions of care. And it's something that's really fascinating, which is basically kids coming adults and making sure that they have those health literacy skills to navigate the exceptionally complex healthcare system, and then know how to do that. Because I think sometimes as healthcare providers, we assume that when someone's an adult that they have this innate knowledge, but they don't always. And so sometimes I think we all have different and then the patients have an expectation of us and we have an expectation of them.
Yeah.
And when that doesn't align, it can create
Hard.
a really not great relationship. So
I want to hear from our younger people on the screen about you did this work. So kudos to you for having done this work. This is really awesome. And I really appreciate the expertise you brought here today. I wonder if your findings aligned with kind of your own feelings about healthcare, if you don't mind me asking.
Yes, for me, I am an emerging adult. I'm 22 years old. And so this aligns perfectly with what I think I've seen, at least with me, for example, with my OBGYN. Even though I get the correct information from her, she tells me all of the answers that I need to hear. But because there's no rapport with a relationship, I'm never really truly comfortable to then ask follow-up questions and more questions to come. So more so, I feel like we're treating the issue at hand when I come into the office, but there's no preventative care of moving to the future and talking about different things like that. And so I see this now where because I didn't feel comfortable to address those issues right then and there in the room with my OBGYN or my primary care physician, then I go home, scroll on the internet, ask ChatGPT. I have done that before, so I definitely understand. And I think that's where the barrier is of that relationship and rapport to really trust your provider.
Is that why you want to be a doctor, so that you can be better than the generation?
Yeah, one of the reasons for sure.
All right, Eliana and Taylor, what about your experiences?
Yeah, so I agree with Jamie completely. I think that it's important to kind of, and I do this myself, but you kind of look online. A lot of people kind of flock to online forums and different kind of mediums because those people are also experiencing the same thing you are. If that makes sense. So it's kind of easier to talk to someone and feel more validated in what you're experiencing than it is to talk to a provider about something maybe you don't know if that's normal per se, or you don't know if that's healthy or, whatever. And it could seem scary. And I think that sometimes, when you're experiencing that, you kind of look online for people that are also going through that too. And that's why on my infographic, I also included, if you see some kind of thread on social media and you're following that, bring that to your healthcare provider, show it to them. Hey, these people are talking about this. I'm also experiencing this. Can you talk a little bit about what they're sharing? And is that credible? And can I follow that, advice or whatever, so.
I want to give Taylor and Dr. Schlegel the last word. And if you think a little bit about what message do you want us to walk away with regarding young people accessing healthcare and how we can do a better job?
I feel like when I have a health issue and I visit a physician, I often have a lot of anxiety and I go there and I just resolve the problem at the clinic. And then when I leave, I feel like I didn't ask enough questions because I didn't feel like I had a connection as much with my physician. So I refer, like Eliana said, to online resources, being like, who else has experienced the same thing that I have? Because I was too scared to ask, or it didn't come to mind what I should do to prevent such problem in the future. So yeah, I would definitely say just making it more comfortable, because I feel like my age group, it can be hard for us to be like open and trusting and communicating with people. So I definitely think that's definitely a prominent issue for me as well. So
Thank you.
I'll just say I'm so proud of the three of these women. They have done a great job. But I guess I'll leave it with I had one more slide about trust building. So mutual trust between the provider and the patient. So trust, like having the patient trust you, but also trusting your patient to know what's best for them, and making that clear in the interactions. And then voluntary reciprocity, if it's something you're comfortable with, like sharing about your own health experiences, I think can bridge that gap. And then always trying to squeeze in a little bit of prevention during all of those episodic interactions. So asking, about future pregnancy desires and intention, and then kind of following up on that, I think is important to try and squeeze in when you can.
Well, shout out to your team. The future is bright. I'm so thankful for all of the work you've done, and we look forward to seeing all of you in your future endeavors. So thank you so much for this wonderful expertise.
Thank you so much.
Thank you. We're going to shift a little bit and talk about something less fun. We're going to talk about prescription drug costs. And the way we're going to make it more fun is that we've got people here to help us think about it and think about how we can tackle it. So Dr. Taylor, take it away.
Okay, because we just had that amazing conversation, and I was trying to make this wonderful presentation that basically distilled why drug prices are higher in the United States, which is a super complicated problem. And I think we can probably hold off on that presentation, because I think it's super fascinating, but definitely not necessary to have a discussion about all of that stuff when we have such wonderful people here to kind of talk about what we're doing to kind of combat those sorts of things. I think that's a bigger thing.
Absolutely. So why don't you tell us what the high points of what you want us to know, and we'll save the history of how our system got to where it is for another time, if you promise.
Yes. No, it's good. I think the high point is that it's complicated. It's an exceptionally difficult process, and there is a ton of finger pointing that goes on of who is to bear the brunt of why drugs are as expensive as they are, and that there's this big disparity. And I will say, kind of the other big point and takeaway is that in the United States, we pay a significant amount more for pharmaceuticals because of our relatively unregulated marketing process, which is a lot different than almost all of the countries in Europe, Australia, Canada, and some Asian countries as well. And so there's multiple different ways that kind of the system breaks down with that. But at the end of the day, we end up paying more because of our relatively unregulated market in that way, and a very complex system of patents that they also have in the United States. And so it's hard when we're talking about how to reform the system, because it's definitely not a one size fits all approach. And I think that's a big thing. So one of the solutions is something called the Prescription Drug Affordability Board, because I wanted to shout that out because myself, Dr. Harris, and Senator Cherry are going to be having a town hall later today at the library, the Gloria Coles Library, from 2:30 to 4, and also going to be live on Facebook too. So if you want to hear more about that and that potential solution, happy to do that. But I want to talk about some things that are actually going on right now too in our community, because there's a lot to help make prescriptions more affordable and much easier for individuals to access their drugs.
Awesome. Jim, I'm going to give it to you to take it away.
All right. Heatherlyn, can you put up those slides? Thank you, Dr. Taylor. And you're right. We have a complicated prescription system that we have, and but I just want to highlight a few things that I think are available that are working. And so couple things that I want to talk about is insulin. If you've ever taken care of a loved one or you're on insulin, you know that prior to about a year or so ago, those costs were astronomical. They just a lot of times, especially seniors, would go not use insulin or not fill their prescription because it was way too expensive. But we criticize a lot of times the federal government, but in this case, the federal government came through, passed the Inflation Reduction Act in 2022, and that put a $35 a month cap on insulin costs for Medicare recipients and established $35 a month programs for non-Medicare, these caps. And so they've been invaluable. If you are on insulin or are a caretaker like myself of someone who is, this is a game changer because you were probably talking hundreds to $300 worth of insulin a month that was needed, and so this really has been working, and certainly, and then starting last year in January, because of pressure from Congress and from the administration, pharmaceutical companies reduced their cost of insulin by like 70 to 80%. And it was one of those things that you're like, is this really going to be the case? Do we believe this? And it's just been phenomenal, the savings. Even at the health plan, we have seen just dramatic reductions in what we pay in our claims for insulin. So there is hope out there. I think we just have to kind of reunite and really work. I'm very interested. I'll be attending the session this afternoon because I think we have to use our elected officials, educate them on a need and a problem, and then look for some solutions. So excited about that. But there are some, if you go to the next slide, there are some local, if you're struggling with prescription drug costs, there are some resources. One is more of a national resource. It's called GoodRx. It's a web-based tool that you can use. Let's say even if you're on a commercial insurance and you have a very high copay for your medications, you might be able to save money through the GoodRx system. Basically, it shows what negotiated prices are at different pharmacies. So you can type in what medication you're on, what pharmacy you go to, or your zip code, and it'll show you how much you can pay out of pocket for that medication. And it's a great tool. It's very easy to use, very simple. And for a lot of people, this is a game changer as far as saving them dollars, especially if they're paying out of pocket or they have these really high copays. So I would certainly recommend using that. Our great partners at the Genesee County Free Medical Clinic have a program there called the Dispensary of Hope. There's an entity, a nonprofit in Tennessee that gathers unused or undistributed medications, and then they get them to places like the Free Clinic and others. And so they have a whole list of available medications. It might not have yours, but it's worth a try. And so those are free. So you can certainly contact the Free Medical Clinic to see if there's a medication that you're on that right now you're paying out of pocket for that could be available to you free of charge. So I would check that out. And then the Genesee Health Plan, since our beginning, has been doing a prescription assistance program. Next slide, please. Where we can help people in the community get medications prescribed by their physicians that are not covered under Genesee Health Plan or their own insurances. So not all the time are medications covered. And because a lot of times medications that are covered under insurance are what we call generic or lower cost. Some of the new ones that come out sometimes aren't covered. And so, but they can still be made available through the pharmaceutical companies. Basically, you're applying to get those free. And so our staff are trained And I think there's other staff around the community at different places that can sign people up to the pharmaceutical company, work with their doctor on getting the script to them, and then they get those medications free, basically. It's almost like a scholarship, so to speak, on that. And so because sometimes there's alternatives as a physician. You have some choices, but other times you really are wanting to have something really work for a patient you think they could get good results from. And let's not make it where it's a hindrance where, it might not be available, that's paid for by their insurance. So that's certainly a available option. Next slide. And so each drug company has their own eligibility guidelines. We at Genesee Health Plan can help Genesee County residents. You don't have to be a member, and there's no cost. There's never a cost for us to help you with that service. Next slide, please. Last year, we were able to do 129 of these applications that were approved, and this is phenomenal. And I really I praise my staff all the time, but they were able to save people in this community $1.6 million in medications that they received. We calculate that using GoodRx's Walgreens retail costs, so there could be even some fluctuation with that, but there is hope out there, or there are some options. So, I would encourage you to think about that. Next slide, please. This kind of, and so these are some of the conditions or diagnoses that the medications that we got through prescription assistance are. You can kind of see a variety. Mostly they're the diabetes medications, but others, asthma. Again, those inhalers and other medications are very, very expensive. So all kinds of a wide range of diagnoses. And then the next slide, Dr. Taylor was talking about marketing, and sometimes I think we pay for the marketing that's done. You can see these were the highest ones that we did the prescription assistance on, and it's almost like a who's who of all the commercials that you see on prescription drugs, Ozempic, and all of these that are good. They help people, but they're very expensive and a lot of times are not covered. So, but a lot of these are really heavily marketed, not only to the patient, people watching TV, but also to physicians and health practices. So, so these are the ones that the specific medications that we have assisted over the years. Next slide, please. And so these are the resources that are available. The GoodRx website. You used to have to print out a coupon and go to the pharmacy. Now you can basically, when you're at the pharmacy and you have a medication that's going to have a very high copay, or you're paying cash a lot of times, ask for the GoodRx and they'll run it through GoodRx, and a lot of times there are savings out there. And then if you think if you're helping somebody and can help people fill out a prescription assistance application, they're all on this what we call needy meds. And so there, again, I would recommend looking at that site as well, and it'll show which ones have availability through the pharmaceutical companies. And I know there's some chats out there, and Jamaica Thomas from our staff, a longtime prescription assistance coordinator for us. There's just, it's something that I think we need to kind of get the word out more. But there are resources here in our community to help with this. But I'd love to hear a little bit more at some point from Dr. Taylor, because this is an issue that we've been dealing with the health plan since 2001, but I don't think it's going to go away.
No, I want to bring a couple people forward. We've got Cecilia Rutherford from Hamilton here as Chief Operating Officer, a lot of really great expertise. We can bring Nurse T and Dr. G forward too. Just a wonderful group of people who can speak to this issue that we experience in the community, both as providers or people trying to solve this problem. So I saw you trying to unmute. Go ahead. Oh, you're still muted, Cecilia. There you go.
Hello. Hi, thank you. Thank you so much for this opportunity. I'm excited because I do want the community to know that Hamilton have 2 clinics. We operate in the 3OB program where we give meds at a discounted cost. So one of the services, we know we lost our Rite Aid services. We have clinics. We have one at our Burton office at G3375 South Saginaw Street. We're open from 8 to 5. And 2900 North Saginaw Street at our main clinic, and we're open from 8:30 to 5. And one of the things you want to offer that service, you can come to our clinic even if you're not a patient. Our number is 810-406-4246. I'll put it in the chat. But if you're having issues with your patients not getting medications, the Lone Walgreens line, we are open. We're available Monday through Friday. We're working on some off shifts and some Saturday shifts coming soon. But one of the things I want everybody to understand is that the sooner the patient get the medication, the better off they're going to be able to take care of themselves. And you get it at a discounted cost. 304B is for the vulnerable patients. It's for the lower served community. And we need our patients to take advantage of it. And I just hired some PAWs, which is called pharmacy assistant workers. And we're going to work on those medications when people are in the clinic. They don't have assistance, calling the drug reps, trying to make sure we can get these medications offset to their homes. I'm just here. I know it's my first time. I'm excited to be here. I want to go back to the nurses' presentation. I thought it was awesome. They did a dynamic job, but I also want to uplift and highlight our federally qualified healthcare center in town and offer these resources. We have to start plugging everybody in to get all the resources they need so we can have a healthier community and not just come to be at Hamilton when you're sick. We need to do preventative medicine and we need to work together as a community. We are here. Our light is on. If you have any issues, you can always reach out to me. I'm so happy to be back home. I'm a Flint born, Flint native, Flint baby. So thank you for this opportunity.
You have poured into my spirit just hearing you. And everyone on this webinar knows that now you bought yourself an email from me asking if my students can work in your clinic.
I'm excited. We just had 14 University of Michigan Flint students that never had experience in healthcare centers, and they were surprised because I brought a group of nurses. Yes, and they just finished their rotation. We're working with raw students. Anyone need a rotation from nurse practitioners to nurses to physicians, let us know. We are here to serve.
Well, email forthcoming. See, we make connections on the webinar. Thank you, Cecilia. Super appreciate your expertise. I want to hear from Jim. I want to hear from Dr. G. I want to hear from Brittany. Tell us kind of what you're experiencing, what you're seeing in your own practices, and what we need to do better to make sure we're connecting to resources like Jim at GHP and to Cecilia at Hamilton.
Okay, I'm just going to highlight Michigan United does have a campaign called Care Over Cost, and that helps community members connect with access and access in the community, and also work with their insurances to get those services covered. So I dropped in the chat. It's careovercost.org, and you reach out there, volunteers, and it will help you negotiate with your insurance companies for billing like things are denied, prescriptions that are denied. So I just want to highlight that campaign that they're in the community, help you also to navigate through the healthcare system.
Awesome. I saw Jamaica pop on and she put in the chat that meds can be donated to the free medical clinic as long as they're not expired. All right. That's good to know. We'll make sure we get the resources over to you. Thank you, Jamaica.
I'll just add real quick, it should also not be opened if you're donating them. Like that's more stuff they have to go
Dr.
through.
Harris forward. I think I heard her. Uh-oh.
Can you hear me?
Yeah, there you go.
Oh, I was just saying with the donated meds, it's ideal that they aren't opened because they have to go through a lot more processes to address contamination risk.
Okay. So unopened meds, make sure you get those to Jamaica and the free medical clinic team. Can you throw in the chat where they should drop them off? Like what location and how they get them to you? Any last comments? We have 2 minutes, but you all have had a wealth of expertise, and I really think all of these resources are going to be great for Flint.
Oh, can I make a comment?
Please.
Hi, every bit of information has been wonderful. One thing I do want to share is that what we're finding out in the community with medications is that they're not getting their prescriptions filled. They're waiting to the last minute. And then
when they do try to get into their healthcare provider, they may have to wait a couple days, but they've already went 1 or 2 weeks without their prescriptions being filled. So even though we know that there's barriers and we have some issues with them getting the medications, we also need to prioritize. If you're out of medications, if you're down to your last week or two, make sure that you're putting in, the efforts to get those prescriptions filled. Yesterday, we were in the community taking pressures, and probably 10 people was hypertensive, stage 2 or higher, because they didn't have their meds filled.
We have people in the community who ran out of medications, weren't able to get them. So we're talking about cost once you have the prescription. But if you haven't gotten it written, gotten it called in from your provider's office, then even getting to the next barrier is something we need to think about. So make sure as soon as you're down to about a week, get that call into your doctor's office so they can have some time to get that medication sent over for you.
And some pharmacies will give longer prescriptions.
And also talk to your providers about 90-day prescriptions and making sure refills are available on those, and talk to your insurance companies about what that looks like and make sure you have the coverage. We have had one of the most wonderful conversations today. Always a really, really wonderful opportunity. It's the sorors. We have the Flint alumni chapter of Delta Sigma Theta. Shout out to Delta with the Black Maternal Health Summit, which is Thursday, April 17th. Love to see the wonderful people doing great work. And I see one of my favorites, Dr. Janae McCoy-White and Dr. Kenyatta Dotson. We got some wonderful people with some wonderful expertise. We will see you next month. Thank you so much.